Detection of myocardial ischemia, you can detect it by ECG, nuclear imaging, PET, stress echo, cardiac MR. We have enough and more. If you look at the ischemic cascade, the first thing which happens when you close off or tie a dog's left anterior descending is that first thing which happens is that there is an acidosis which happens in the coronary sinus. Then there is flow heterogeneity. Then there is a if you do a scan, you'll find that there is hypoperfusion. Then there will be a diastolic dysfunction, and last two occur are ECG changes, and beyond that, angina occurs. So we need to evaluate several things in suspected or known CAD to risk stratify patients before surgery, before MI, before PCI, before bypass, and apply in non-coronary artery disease. Now, where are we looking at viability? We are looking at a fight for a single space, and that single space is viability. There are several modalities, and disadvantages of one modality becomes an advantage for another. And then there are several other factors which kick in: availability, expertise, time taken for the test, cost, bias, radiation, exposure to dye, kidney function tests, metals in the body. All those things kick in, but those are more of debating points rather than real any substance in it. Despite the fact that I am an echocardiographer, I shall try to be as non-biased as I can. We'll talk about, since I have got only 10 minutes, I'll have to just give the sum and substance of everything. Determinants of clinical outcomes in coronary artery disease are atherosclerotic burden, coronary occlusion, extent and severity of ischemia, LV functions, LV volumes, plaque morphology, whether it is stable or unstable plaque. The experts are already here on the dais. I'll not enter into their shoes or their sandals for that matter. The modalities which help are nuclear imaging, cardiac PET and PET CT, cardiac MR, cardiac CT, echocardiography. And all the modalities are trying to attain the status of one-stop shop modality. Let me talk about one thing at a time. Talk about the myocardial perfusion imaging. If you look at this graph, the ones on the bottom are the ones at rest, ones on the top are the ones on stress. If you look at it, or redistribution for that matter, it looks to be stress. Now, if you look at this, the moment there is a person who goes on a stress, two things happen. One is the LV dilatation, which happens on the top one, and there is a change in the color and the quantum of area and the quantum of ischemia, both can be quantified. So you are in this manner, you are trying to quantify the area at jeopardy and the ischemic zone. Where is the problem? The problem is infrastructure. Regulators in our country are terrible. Radiation exposure to the personnel. Now, this has been always a debating point between CT versus MPI, that which is the one which gives more of radiation to the patient. No, I'm not talking about radiation to the patient. It's a cumulative effect, and more than the patients, it is the personnel working there which matter to me. Cost, and of course, you have to be an expert in it. MRI, again, the issue and advantages and disadvantages are several. To name a few advantages: no radiation, no iodinated contrast, excellent spatial resolution, subendocardial ischemia can be seen very beautifully. High soft tissue contrast, MRI, they themselves are a contrast to each other. Body tissues. The disadvantages are moderately long time to take measurements, claustrophobia, pacemakers, ICDs, heating wires, arrhythmias, technically complex. Subjective interpretation, not so much these days, but yes, it is the man behind the machine which matters regardless of what modality you are using. Not well standardized for several things. For several things it has been standardized, for several things still the world is evolving. And unfortunately, when it comes to coronary arteries, MRI is way behind CTA. PET and CTA have a big advantage that they can evaluate viability even in resting situation. The disadvantages continue to be the ones which I have already mentioned for myocardial perfusion imaging and CT angio. But if you look at the contraindication for stress, these are several: acute MI to severe aortic stenosis to large aneurysms to pregnancy. The list is long. I'm not going into the debate kind of a situation. But when it is something where you want to establish viability, then probably this modality comes in best because this can be done at rest. Echo, again, the issue is it has a learning curve, it is subjective. You have to be familiar with the equipment, awareness of optimal transducer position, not to change field of depth during entire study. These are certain cautions. Analysis based on wall thickening, which is again a very subjective issue for evaluation. LV dilatation, systolic dysfunction, and hypertensive response, they can be confounders. Arrhythmias, you can capture a wrong frame. Now, these are certain pictures which are dramatic pictures. No, they're not that dramatic because something has gone wrong. Okay, you can find out ischemia, you can find out hibernation, and you can find out stunned myocardium. These are three things which are very, very confusing, but all these things can be sorted out on all the three modalities or four modalities that I have talked about. But echo does it very easily, simplistically. The problem is that it's very specific, but it is not that sensitive. So if you look at the diagnostic sensitivity and specificity when it comes to scintigraphy versus echo, the sensitivity is high for MPI, specificity is high for echo. When you say specificity is high, that means post procedure the predictiveness that the person will recover is higher. Again, not to go into the numbers, these are all things which are shown by everybody depending upon which modality they are debating for or pitching for. But to cut a long story short, they almost have all the, thank you very much. They have all the debating points and the numbers in favor or against depending upon which study you quote or the which meta-analysis you quote. Actually, it is a toss a coin situation. When it comes to head-to-head comparison, when it comes to picking up viability, thallium scintigraphy, this is 1995. Thallium scintigraphy picked up viable tissue more often than dobutamine stress echography. But the issue is that when it came to recovery post intervention or bypass, the recovery was better where echocardiography was positive. Women and ischemia are a little dubious situation where, again, if you really want to trust something, especially in pregnant ladies, then the sensitivity and specificity for echo is reasonably good, if not excellent. We know that there are certain false positives and false negatives in women. There are certain prognostic indicators which have been calculated by stress echo, and cardiac event rate per person per year of follow-up was 0.9% when the echocardiography was negative. You can score them, you can calculate them, everything has been done and evaluated time and again. You can predict mortality, though not perfectly so, but this also has a limitation. It is dependent on image quality, influence of LV cavity size, need for specific training, discordance burden, role of myocardial contracts. But why this controversy? The Brahm question is, Brahm Prashna as they call it, is that why is the controversy of ischemia or viability now surfacing? This was in 2005. Eugene Braunwald writes, mechanical revascularization is probably being employed too frequently in the United States. Sorry. And that's the reason why the controversy started. Do we revascularize all? You don't need to, because the cost of revascularization for severe LV dysfunction is too high. The perioperative mortality is 5 to 20%. Just give me 2 more minutes. This 2 minutes is because I've been having a bad throat. So I took pauses. Thank you. Yeah, Vishal is not here. So when do you do? Recommendations are if you have more than 4 segments in dobutamine stress echo or more than 15 to 20%, depending upon what other imaging modalities you take, you are comfortable. Now, should you revascularize? Yes, you should, because recovery of myocardial contraction is better, prevention of remodeling is there, stabilization of electrical milieu, so arrhythmias are lesser, prevention of subsequent MI, improvement in diastolic dysfunction, improvement in heart failure symptoms, and improvement in overall outcomes and survival. This is the reason. But benefits of revascularization in viable myocardium. 24 meta-analysis study 2008, it says it should be done. Very good, excellent. But paradigm shift came in 2011. It says there is no significant interaction between viability status and treatment assigned with respect to mortality, none whatsoever. And the debate restarted. So a trial was picked up, and this is long-term 10 years follow-up trial where they did bypass surgery in patients with ischemic cardiomyopathy, ejection fractions of lesser than 40% or 35%, and they revascularized with viability on objective assessment and without viability. And lo and behold, what did they find? The conclusion was that Stitch, this was the trial's name, Stitch at 10 years confirms benefits of surgical myocardial revascularization over optimal medical therapy in patients with reduced ejection fraction. Consistent benefit of bypass over PCI for multivessel disease in all randomized controlled trials and registries. Importance of viability or presence of ischemia to guide decision making was not well established. So Stitch kind of endorsed the earlier suspicion which was given by paradigm shift, that do whatever, do a surgery, you don't need to assess viability. So the impact of myocardial viability making decisions was very, very dubious. And these are excerpts from Stitch trial, that myocardial viability was associated with improved mortality but not predicted a benefit compared to those without myocardial viability from revascularization, regardless of how, why, if you have good target vessels, bypass them. Oh my God. So this is something which happened. So the debate of believers versus non-believers continue, because this came in 2013, and despite this, American College of Cardiology said that no, we'll continue to keep viability as a very strong class of recommendation. It was class 2A before this thing. So despite the fact that Stitch was there, they continued to believe that you should test the viabilities. So 2019, again, the conclusions of this long-term study follow-up was that the findings of this study do not support the concept that myocardial viability is associated with long-term benefit of bypass in patients with ischemic cardiomyopathy, and the presence of viable myocardial was associated with improvement in LV systolic function irrespective of treatment, but such improvement was not related to long-term survival. So what was it related to, if not survival? It was certainly related to the quality of life. So this is something which has been underplayed all the while. I personally am a believer, because if you are a believer, why am I a believer? Because objectivity leads to confidence to subject a patient for a high risk procedure like bypass surgery, which has got almost about 10% risk in a poor LV. So you have to have some objectivity, if not because of Stitch, but at least to console your own conscience that you are doing something right. And number two is that in atypical symptoms, cause and effect relationship can be better defined. Thank you very much for a patient listening, and thank you for allowing me to speak.